Clarice. Thank you for joining us. She's going to be our speaker today. Clarice Goas, APRN CNP, is a nurse practitioner who received her master's degree from Ohio State University College of Nursing in Columbus, Ohio. My friend would really want me to do the OHIO for her, but I'm not going to because I don't have it perfected like she does. She works in movement disorders at the Ohio State University Wexner Medical Center. Clarice, thank you so much for being here today.
Happy to be here. Shall I get started?
Please.
Perfect. Okay. So let me just get things moving just a bit here. Okay.
Clarice sets up. She did also agree to share her slides so that those will be available as well tomorrow. So thank you again.
Absolutely. And here we go. Can everybody see what they need to see? Perfect. Okay, well, thank you so much for inviting me. I'm always happy to talk at these. I have a particular passion. I am a movement disorder nurse practitioner, but my dad has Parkinson's disease. So that is why this is near and dear to my heart. I did work in primary care for a few years, and then we bobbled around to a few different movement disorders facilities. And I finally decided that I needed to know more than everybody else to take good care of him. And so here we are 10 or 12 years later. So I've been doing this for a little while. So today we're really just going to talk about why we have a comprehensive care team and why it's so important to have all these people on your team, you know, not just one doctor or one nurse practitioner or what have you, but why having all these people can really make putting up with this disease a little bit easier. So we'll talk about that. Also happy to answer questions. You know, we'll try to answer them at the end, but if something's really burning, then, you know, we can always get to that as well. So without further ado. So these are just some of the things that we're going to talk about today, which is, of course, when to start asking for other people to be on your care team and then who those people should be. Making sure that we understand the importance of the support system, learning what nurse practitioners and physicians assistants do, and then just a lovely little way to say how to get the most out of each appointment when you come see us. So that's what we'll be chatting about today. So this is one of my best slides for the multidisciplinary care team, but I will tell you, I still don't think all the people are on there. So there are lots of important people to help manage Parkinson's disease. Of course, some people really only need their neurologist, and you know, that's perfectly fine. But we really kind of need the whole picture. So we'll spend a lot of time talking about some of these and then a little less time talking about some of the others. But if you have any questions about some that we don't touch on as much, please feel free to ask and we'll talk some more. And of course, it's Parkinson's disease itself is not a one size fits all at all. So of course, you also won't need every single one of these people. But I think it's important to know that these resources are available for you and, you know, when to ask and who to see and who helps with what. So we'll talk quite a bit about that. Okay, so we'll start off with Parkinson's disease and exercise. Probably your care team has talked to you a lot about this, but maybe not. Sometimes we're remiss on it and we focus on the medications. But exercise is the only thing that we know right now that can help delay the disease onset and slow the progression of PD. There are about 50 things in trial, give or take, that we're looking at to try to slow down the disease, but we're positive about the exercise. So one of the biggest people on your care team that we like to talk about is the physical therapist. And so we'll talk a little bit about that as well. But there are good studies, good reputable studies showing that essentially all physical activity is really good for Parkinson's disease. I actually don't like the treadmill myself for my patients. So you can ignore that one if you don't like the treadmill either. But lots of good things to do, and we'll talk about them in a little bit more detail in just a moment. So a lot of my patients ask me, what can I do to help manage my PD? And I always say, well, you can exercise. And then they'll of course ask me, well, when should I start doing that? And my answer is, you know, yesterday. So it improves all of these things: the heart function, circulation, respiration, balance and mobility, strength, flexibility, endurance, and even your mood. So kind of self-esteem and things of that nature. So It's really important to exercise. And a good way to start exercising is with a physical therapist. But my patients always ask me, but why is it so important that, I start setting up this connection with the physical therapist and I'm working out and I'm exercising? What's so important? So there's something called neuroplasticity, which means even with Parkinson's disease, it's possible for us to change your brain and to actually change the structure and the function of the brain, which is pretty incredible when you think about it. So really, even if you have PD, you can improve how your brain works. You can kind of make it work for you through this concept of neuroplasticity. So the changes occur on 3 different levels: chemical, tissue, and functional. So we actually do see changes in the brain that last if you're exercising and moving around. And this is just a slide that explains neuroplasticity. But again, what it means is that the more often you do something, the more you practice. This particular person is practicing darts. I don't know how helpful that is to us in real life, but if you practice, eventually the brain actually builds these new connections. And the neurons actually do a better job of what they're supposed to be doing. And we see improvement, particularly in gait and balance is a big way that we'll see this. So we're actually changing things on that level. And so this is again, it's the same thing, but just a little bit different. But there's goal-based exercise and aerobic exercise, and these are some fancy scientific ways of the things that actually change. But as you'll see, there's a whole lot of things that truly change in the brain when we exercise with Parkinson's disease. And what's most important to me are the outcomes. So your motor, both your conscious motor and your automatic motor functions can improve. Your cognition improves. The executive function, which is kind of your ability, your higher function, your ability to make decisions and do some of those things can actually improve. And then your mood and motivation always improve as a side effect. So it's a good thing. Okay. So if you exercise with Parkinson's disease, you can improve your motor symptoms, your slowness, your balance, and your walking. And then your non-motor symptoms of cognition, sleep, and mood, and autonomic dysfunction. Now, we all know that our patients tend to have a lot of trouble sleeping, so anything that can be helpful from this aspect and exercising early in the day can definitely help. They've even done studies where they have actually proven where if you're exercising, you can reduce your drug side effects and enhance how well the medication works. So it's a big deal, hence why we've now spent 5 slides talking about it. And a 6th. So we'll see the same thing here. But again, it can improve both your motor and your non-motor functions. Interestingly enough, our patients, sorry, I'm moving my Zoom screen. Our patients who exercise to begin with often present much later in life with the disease with more mild symptoms. Exercise is actually protective of Parkinson's disease. So is caffeine. Interestingly, so if you drank coffee for years, you probably delayed your onset a good bit. So, caffeine is a good thing for once. But I'm back to the exercise. But it can improve all of these things, and it's good for you. So, wrong way. Okay, so really back to what we're talking about today is when you want to seek out physical therapy. It's essentially as soon as you get the diagnosis of Parkinson's disease. I try to send my patients pretty quickly, at least to get an idea of some of the things that you can add to your normal everyday repertoire of what you're doing for your disease. But some actual studies, not just me telling you things, but some evidence-based medicine, as we like to call it, things that they've studied very intensely. So do you have bradykinesia? So bradykinesia just means slowness of movement. It's what we're looking for when we make you do this a whole bunch. We always want you to tap your fingers and open your hands and turn them. So it's those movements. It's kind of what most people would refer to as fine motor movements. So if you have that, they did a couple of studies. They were pretty interesting studies. We're even just squeezing your quadriceps 3 days a week improved the leg movements and their quality of life for patients if they did it for a specific way of training for about 3 months. And then here you'll see something similar. There was another trial where they had a 3-month, 2 sessions a week, and they did high-speed power-based resistance training. So sometimes that means weights, sometimes that means bands, just depends. And it decreased that, it made the patient able to use their hands and legs, and that fine motor movement better in both the upper and lower limbs. They were looking at mild to moderate PD, but it worked really well. So again, just the importance of moving and staying functional. So another time to seek out physical therapy is if you're having trouble walking. So they've proven that the exercise and the physical therapy can improve balance, posture, and gait control. And even just 4 weeks of gait training, that's often, the LSVT big that we hear so much. The physical therapy specifically for Parkinson's disease. It's usually 4 weeks, although most people can't do that because it's supposed to be four days a week for 4 weeks. Most people end up doing 2 days a week for 8 weeks. But it can improve your walking speed, your step length, and how long support time. So how long you might need like a cane or a walker or something. And just doing 4 weeks of this training can improve your gait for up to 3 months. That's how long that effect can last. Going back again to that neuroplasticity, you're actually changing your brain on a chemical level, making it a little bit easier to walk. And then same thing here, patients who have trouble turning, sometimes we'll refer to this as gait freezing. They did a study where they did 12 to 13 minutes of specific turning exercises for 4 to 6 weeks, and it greatly improved the gait and the ability for those patients to turn. I really like to use physical therapy in my patients who do have gait freezing. It's our best treatment for it. Sometimes gait freezing is responsive to medication or to deep brain stimulation, but truly the best studies that we have show that it responds the best to therapy, physical therapy. So I'll often order, depending on my patient and if they're up for it, but I'll often try to order it the maximum amount of times per year, which tends to be 4. As you'll see, usually these effects last about 3 months. So if we can keep you in therapy 3 to 4 times a year, that usually can keep your gait and your walking as best as we can make it. Decrease your risk of falls, serious injuries, having to use a cane or a walker, those kinds of things. Although sometimes we still have to use those things, but this is kind of our best way of managing some of that. But should I really do it? Because it's a big time investment. You have to leave the house, you have to get dressed, you have to get ready to go. We all kind of got used to staying home during COVID and enjoying our own homes. But it really does. Again, here's my thing to discuss is that the balance training can improve balance and reduces fall rate for 12 months. Even just doing it once can reduce it for 12 months. Tai Chi, there's a lot of evidence with Parkinson's and Tai Chi, and usually a local group or 2 you can find. Doing that improves motor symptoms for 6 months. They've got some trials with dance therapy that said that it improved patients' balance and walking for 12 months. Progressive resistance training, that's like lifting weights or using bands. 2 years, they found out that the patients had better mobility. And then they even did a trial where they actually showed that physical therapy itself professionally slows the decline and restores the functional activity in PD patients. And that was some years ago in 2017. So that's not a new trial. And then patients ask me how long. Most of the benefit, the trials point to at least 30 minutes a day, most days of the week, is what we're trying to hit more than anything. But I always say, just make sure it's something you like to do. Physical therapy is important, but if you're going to maintain something outside of physical therapy, then, there's a lot of studies about riding an exercise bike and things, but if you really hate doing it, you're not going to do it every day. So don't make yourself do something you hate. Find something that you like to do for moving. And honestly, it's most likely to make you more mobile longer. So again, choose something you like. Okay. Whoop, sorry guys, I have to move you again. Yep, and it also not only, so we just talked about some of the physical things that it improves, but not only physically, but again, going back that it's going to improve your cognitive function. Moving around, getting blood flowing to your brain actually makes your brain work better. And secondly, I know I've said it once before, but I'll say it again. Exercise also improves how well your levodopa works. It makes it work better, and it can decrease your risk of getting dyskinesia, which are those wiggly movements like Michael J. Fox that a lot of our patients do not like to have. So yes, it really, 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 really is worth your time. Okay, so we'll switch gears. I've told you several times why I think it's important to have a physical therapist and some exercise on board as part of your Parkinson's care team. So speech therapy, when do we want to seek them out? Well, they actually have a lot of really helpful things they can help with. That's not just speech related, but let's talk about the speech related things first. So if you're tired of repeating yourself, Parkinson's patients tend to get really soft. And they can become very soft spoken. So if you're not looking at someone, they can't hear you, and then you end up repeating yourself, and then you'll often find yourself just giving up on talking altogether because you're tired of repeating yourself. And we know that that's not good, that it's important to maintain those social connections and, feeling that what you have to say is important, because it is. So if people are asking to repeat yourself a lot, that's a good time to ask for a speech therapy referral. They also help a lot with swallowing. It's a common misconception in Parkinson's that when you start having swallowing trouble, that there's nothing we can do to fix it. And that's not true. We can send you to a good speech therapist. They'll usually do something called a modified barium swallow. So they will do a test, easiest test you've ever taken. You don't have to pass or fail. They'll just watch you eat and drink things dipped in barium, and then they'll kind of look down your throat and see which muscles aren't doing what they're supposed to do. And then once they find the ones that aren't working, at least here in a lot of large centers, they will have the speech therapist come out right after your test, and they'll say, hey, these are the muscles that aren't doing what they're supposed to do, and here's some exercises you can do at home. And so you can do those, and then those muscles strengthen up, and then swallowing is not such a big problem. If they think, they'll also sometimes say, well, I want you to do these at home, but I want you to come back and see me for another round of therapy. And so, they'll let us know, and then we'll order it, and you might see them for a couple of weeks, and they can make sure that you've got those exercises just right. And then a little known thing that speech therapy does as well, which most people don't know about, is they can actually help when you're having trouble with your thinking. So they do a lot of cognitive training as well. So they can really work with you if your memory is struggling or you're having trouble thinking. Speech therapy is a good way to go. We also can have you see a neuropsychologist or cognitive rehab or some other things for thinking, but a lot of those resources aren't available unless you're in a big city or a place that has those. But even just your local speech therapist can usually help with some cognitive treatments and tips and tricks and things to do. So they're good for that as well. Okay, so occupational therapists are another great person to have on your care team. Sometimes their role is not as clear, so I always try to make it clear. They can really work when you're having trouble doing something. Very specific. Patients who have trouble typing, patients who have trouble cooking, patients who have trouble doing anything, one in particular, they can help you use your hands as best as possible. They've got all kinds of gadgets and tips and tricks and things of that nature. Also, if you have the home occupational therapists, they can come out and look at your home, and they can look at things that are dangerous or things that give you increased risks. Fall risks and things like that. So they'll often come out and do a home assessment and just kind of help you get some of those. Or, if you need things like bars in the shower, things, sometimes they can help move that process along and give you recommendations on what you might need. So they're really great and we love them quite a bit. And so they're good parts of your care team. Social workers are another group of people who are really important to have on your care team. They can do so many things. They often help us when we're coordinating home health or other home services, folks coming out to the house, giving you a hand, home health aides. They're just really good at coordinating those local services. They also can just tell you what services are available in your area. Where are the support groups? Where are things like adult daycare, or where can your caregiver get some respite? They have all those things. They also may know if you're they're really good at transitions. So if you're transitioning from working to maybe working on disability, they can help you navigate some of that paperwork and getting the information you need for that. Or if you're transitioning from maybe you can't live in your home anymore and you're looking into like a senior living or assisted living, they can help you with those places, what places there are, and give you an idea of what places they recommend in the community. And then you don't have to do all of that research yourself. They're really good at giving the caregiver a break as well. Those are some other resources they may have to get some extra help in the home if the caregiver's feeling a little frazzled or like they have a lot on their plate, and if they could just step away for a few hours or a week, they can help navigate that. And there's a lot of paperwork involved in both disability and the long-term care options. So they can really help you navigate that as best as possible, because it is a lot of paperwork. Sometimes they can also help to make medications. I forgot to put on the slide, but they can help with some of that paperwork for medications, things like Rytari that need some extra special paperwork. They can help you try to find ways to decrease some of these new and really helpful but expensive drugs as well. So they can be a part of that. But pretty much almost anything you can think of, the social worker can at least point you in the right direction. So they're a really good person to know. We try to introduce our patients to them really early on, just so they know who they are, and as questions come up, they can always ask them. So then the other thing is, outside of that, is who's in your support network. It is really important. It's good to have at least one person. Sometimes it's your spouse, sometimes it's your child, sometimes it's your friend. But this is a tough disease that doesn't take a nap. So, we really need as many people as we can in your support group. We also know that if the person who has Parkinson's is female, then the caregiver tends to even have a little bit more caregiver stress. But we also know that the more the caregiver understands about the disease and how things work, the less stress they feel. So educating them as much as possible is really helpful. And so that's what we're doing today, and we'll continue to try to do. So it's really important, again, that your support network can help you battle Parkinson's disease, and they'll do that the better they understand. So it's all, and the more you know, it easier it is to navigate this. So we try to educate everybody as much as possible. If you can attend educational events such as this, that's really helpful. Again, just knowing more about the disease puts you one step ahead. And then, they can also ask questions, although we'll talk about this a little bit later, but, they can help make sure that you get the most out of your visits if your support person comes with you. They did a trial a long time ago, and they found out that we only remember and retain about 20% of what we hear in the doctor's office. So, we could tell you a whole bunch of things, but if you're only going to remember 20%, that's not helpful. I always joke with my patients that I'm not a physician, so they'll probably remember much more of what I say, which is not true, by the way. But then also, if there's two of you, you are more likely to remember things. And so that's a good thing. And again, my biggest thing, which we'll touch on later too, though, is if you don't understand something we say, please just ask us again. Sometimes, remember, we say these things over and over and over again to the point where we feel like you're bored. You don't want to hear this again. But that may not be true. So, if we say something and you don't understand, please, please, please make sure that you ask us to explain it again or in a different way, because we're happy to do so. Okay. So back to our lovely picture here. So we talked about your physical therapist, your occupational therapist, your speech therapist, and your social worker. Of course, the MDS is the movement disorder specialist. So that's usually your neurologist and your nurse practitioner that work together. Psychiatry, they can be really helpful. Some of our patients who are transitioning again from perhaps working to not working, that can be a really big transition. And it's sometimes nice to work with psychiatry or just psychology to help you work through that transition. Because, nobody expects to get Parkinson's disease, and nobody expects how it will change their lives. And a lot of my patients have had a really excellent experience, maybe just going to see somebody, not the whole time, but maybe for a couple of months. And it really just helps to ease all that anxiety with the transition from that type of thing. They can also help with your mood a lot. Often your movement disorder specialist will help with your mood quite a bit. As far as, managing anxiety, depression, sleep, all those things, we're often really good at managing those medications. But sometimes there are certain forms of Parkinson's. Some patients are really, really, really anxious. or they've had depression all their lives, and now they also have a little bit of it from Parkinson's. Sometimes it's good to see the neuropsychiatrists. They usually work with patients who have Parkinson's disease and some of those things. So they're really good at making sure those medications are just right. You probably will encounter the nurse at some point. They're usually the person fielding phone calls and answering all your questions, filling out all that paperwork. And so you are likely to run into them. Dietitians can be important. Parkinson's patients will usually initially have a little bit of a weight loss, not everyone, but most, and then it should level out. After that, we don't blame it on the Parkinson's, but some of our patients just don't feel like eating. Some of the medications we can give you for thinking can decrease your appetite. And just sometimes in general, patients don't feel like eating. So sometimes we'll call a dietitian on board to see what might be a good idea. Or if you're having a lot of trouble with protein, rarely, but sometimes our patients have trouble with their medication and protein, and they can be really helpful. Geriatricians are really helpful. They're essentially like they are your regular doctor, but they look at all the medications on board, including things that are unrelated to your Parkinson's disease. Some of the regular doctors are really, really good at this, your what we call your primary care providers, and some of them not as much. So, sometimes it helps to have someone who studies patients only over the age of 65 and take care of that. Your general practitioner, of course, is on there. Urologist is one we don't talk about, well, I do, but oftentimes we don't talk about them nearly enough. Your bladder can get really, really difficult in Parkinson's disease and be quite a pest. It is good to have a urologist who knows something about Parkinson's disease. There are some decisions that a urologist may not make for you if they're really familiar with treating Parkinson's patients. So if you're having a lot of bladder trouble, it's not a bad idea to ask your movement disorder specialist if they can help out, if they know a urologist or someone that they use quite a bit in order to make sure you're getting the best care from there as well. Because some of those urology meds can wreak havoc on Parkinson's. We say hypothetically that Parkinson's doesn't cause pain, but anything that flares your system, anything that doesn't keep things perfectly happy and normal can worsen your Parkinson's. So sometimes a pain specialist is good. And of course, we may talk about the neurosurgeon if we're talking about some of those advanced therapy treatments like focused ultrasound or deep brain stimulation or things of that nature. So and again, there are lots of other people that may come into play as well, researchers, coordinators, and things of that nature. But this is a small sampling of all of the people who can help manage this tough disease. So besides everyone at the office, you also, of course, can have your family and your friends and your local support group. And now we have all these great, with COVID, we've learned how to do everything online. So we can have these online support groups and tips and tricks as well. But remember, it is good to have a broader support group. I know sometimes it's hard to tell people that you have this disease and you just don't really want to tell them. But I guarantee you there are a lot of people out there who want to help and give their support when they can. And some people say, but I don't need anybody. Well, we all need somebody, whether we have Parkinson's disease or not. And again, if you have a whole lot of people on your care team and they really understand your disease, then that helps to make sure one person doesn't get really burnt out and frustrated. And so then, that increases your ability to be independent longer. And that's a really good thing. It also improves your mood. Okay, so take home message of this first part of the talk. Is that exercise is still the most important thing you can do to battle your Parkinson's disease. And an excellent place to start with that is with a physical therapist who's trained in Parkinson's disease. All the therapies are a vital part of your care plan. The physical, occupational, and speech are really important. And then, of course, having an excellent provider network and exceptional non-provider support system promotes emotional wellness and longer independence. So you need all these people. Okay, so quick transition just to, if anybody is curious about what nurse practitioners or physician's assistants do, because we are popping up more and more in the neurology world. So this won't take long, but just my patients often have questions, so I try to answer them. So an advanced practice provider, you might see that on somebody's badge, it says APP, and you don't know what it is. That just means that they're a nurse practitioner or a physician's assistant. We're all specially trained in Parkinson's disease if you're seeing us in these clinics. So we've all gone through lots of on-the-job training regarding that. We all have graduate degrees. And often we see patients frequently in practices. There's only so many movement disorder specialists around. So you might see the neurologist once a year or once every couple of years, depending on the practice and how many patients they have to manage. And then you're going to see the nurse practitioner or PA. Of course, unless you ask. Most practices, if you ask, if you really have some, you really want to see the neurologist for whatever reason, that's usually a possibility as well. So we're trained. This is all we do all day. So we're really good at it. And we can do everything. Essentially, we can do anything the physician does. We can recognize PD, we can diagnose PD, we can treat PD, we can treat cognitive symptoms. We focus a lot on mood, so we can treat depression, anxiety, apathy, impulsivity, dementia, psychosis, all those things we treat just like the physicians. We can do the appropriate exam, the UPDRS, the one you've all seen, where it makes you tap your fingers and your toes and walk down the hallway. We're all very well skilled in that and specially trained. We have to recertify every 2 years or so, just as the physicians do. We know how to assess cognitive and mood symptoms. We can prescribe medications, and we can titrate medications. We're very good at using them. And mostly we can still conduct telehealth appointments. That changes depending on your insurance and state, but in general, we're still able to do that. And of course, we can answer phone calls and MyChart messages and help every step along the way. We can also place referrals to anywhere and everywhere, all the people we've talked about, including the cognitive neurologist, the psychologist, the psychiatrist, counseling, social work, all the therapies, everybody. So we can also just be another important member of your care team. Okay, so I am actually reaching towards the end of my discussion. I usually find that people have a lot of questions, so I try to leave a lot of time for questions, but we'll see how many we have. Eden, hopefully we have at least a couple.
We do have some questions.
Good. Okay, well, this is, I think, my last formal slide though. But so when you're going, how can I best prepare for my visit? I think a lot of times we're all really guilty of thinking, yeah, I have that visit tomorrow. And, during the course of the 3 to 6 months since you've seen your provider, something will come up and you'll think, oh yeah, I'm going to talk to them about that. And then you remember that thing 2 minutes after you walk out of the door and you've already had your visit. I'm so guilty of that myself. So the best thing to do is to try to write down your questions whenever they come. Whether that means doing it on your phone, or my dad keeps a notebook with him at all times for all of his things, medication times and everything. So when something pops into his mind, he can just write it down and then make sure that he gets his question answered. And then takes that book with him to his appointment. What we really need to know to help you the most, of course, is how you take your medicine. And I know with what we do with Parkinson's, man, we come up with some strange ways of making you take these things. So it's really hard to remember. But, if you can just be honest with us too, if you're not doing what we told you to do because it was absolutely bananas and you couldn't keep up with it, just tell us, because the best way we can help you is by meeting in the middle and figuring out what's actually reasonable. And what we can do to make it easier for you. I mean, sometimes when we're asking you to take, pills every 2 hours, that can be a little bit intense, and we might have a better way of working on that. For example, lots of good things coming down the pike, and some good things that we have out already to help with some of that. So just be honest with us. My dad, he would tell you if he was here, he is the king of messing with his own medications and just doing whatever. And that's fine. If that's how you're going to do it, trust me, you're not going to surprise us. We're not angry at all. We're not mad. We want to know, when you tried some things, what worked and what didn't work. And then, like I said, we can figure out how to best make these meds work for you, without, driving you crazy at the same time, making you take them all the time and things like that. So, and then so write down all your medications, or at least know how you take them. Usually writing them down is helpful, because you might get there and you might be late and parking might be a joke, and then everything gets squirrely, and then you can't remember what you were trying to remember because you're a little frazzled. So it's better to write them down. And then just bring that list of questions, everything that's come up over the past couple of months, no matter how big or small. That's what we're there for. We're happy to answer it. It's great to bring a support person for a second set of ears. Also, they may see things that you don't see, And you might have said no, but they might say yes to any of the questions we have. Also, we always ask you if you move around and talk in your sleep. And unless you have a video camera taping you every night when you sleep, you can't answer that question very well. So it's good to bring somebody with you. And then I always say, I always do this for my patients, but it's good to ask. I always ask my providers to write down exactly what they want me to do, because I might remember when you're telling me right then, but then when I walk out of the door 20 minutes later, I'll think, oh, did they say 10? Was it 20? Was it every 2 hours? I can't remember. Was it 2.5? What did we finally decide on? So ask for those clear instructions, and that way you don't have to write them down and think about them either. And that way you know that they're absolutely correct and you didn't mishear because we wrote them down for you. So just make sure that we're writing all of those things down when you come home, or for when that you can have when you go home, excuse me. If we're stopping this medicine or starting this one, or we want you to take 1.5 instead of 1, just make sure that we write all of that down. And that you understand it. Again, that's another time, ask us again, even if you think they don't want to tell me one more time. Trust me, we would rather tell you one more time than have you go home and be confused and take something cattywampus, or just feel uncomfortable because maybe you didn't quite understand. So that being said, that is the end of my formal talk. It was a little shorter than I expected, so hopefully I didn't bore you too much. But Eden, can we start shooting some questions?
Yep. So, my first question, because normally I go in order if they were asked, but I know this always comes up when you talked about getting the most out of your visits. And I'm sure you've heard this too. People will try and schedule the appointment when they're on or at their best. And so the care partner's like, oh, they're in the office and they're all like this and everything's perfect. And then they get home and it's like, well, I can't move now. And I'd be going like that. And what do you recommend for people? Because obviously they need to be on or they're not going to make it to the office. But at the same time, if you see them only at their best, then you're never going to know what they're like at their worst.
Mm-hmm. So that's an excellent question. And to be honest, we are almost always running behind. So even if you schedule it, we may thwart your plans from that, not on purpose. I promise we are trying. They cut our visits down quite frequently, not because we want them to. But in any case, if everybody has trouble, or if you have trouble, I often ask my patients to take a video. I know that's not possible for everyone, but especially if you have something that you say, well, it only happens at 6 p.m., and we're obviously not going to see you, or it happens in the middle of the night. There are so many different parts of movement disorders. Is it tremor? Is it dyskinesia? Are you off? Are you anxious? Does it have nothing to do with anything? So I will often ask my patients if there's something that they want me to troubleshoot, to take a video of it and bring it on your phone with you if you can, or you can usually find somebody who is willing to take a video. Of course, getting them there at the right time can be tricky, but that's usually my best. I don't really mind if my patients are on or off. I think they prefer to be on. Occasionally I drag them in off for levodopa challenges and various things. So I usually eventually see my patients off at some point, and they're usually not very happy with me, which is fair. I wouldn't be happy either. And so, but it can be either way. I do think it's easiest to understand information when you're on, but again, still telling us when you're off. And if you can get a video, it doesn't have to be long, but if there's a certain particular movement, or just you want us to see what it looks like when it looks bad, give us a 10, 15, 30-second clip. It does not have to be hours and hours, but give us a little bit so that we have something to compare it to. I think that's probably the best way.
And someone asked, and I feel like you touched on it, but I just want to reiterate, why a social worker and a psychiatrist? And personally, as a social worker, having worked in a doctor's office, I would say a lot of it is, I wasn't going to say I never did counseling, but if I did it like once. You weren't going to come see me and follow up with me. I was there more to talk about the resources, to help you deal with bridges to access programs, to get those medications paid for, to coordinate stuff, to support groups and everything. Whereas a psychiatrist, for example, one can also prescribe medication, but also it's more for long-term counseling. Is that correct?
Mm-hmm. Yes, I would say so, especially with some of the medications. We don't use them. Actually depends. Our physicians use them differently. Some of our physicians won't prescribe a lot, or just don't routinely prescribe a lot of the medications for mood, while a lot of us will. It just depends on your comfort level and your practice and what you're comfortable with. But sometimes, a lot of times, we will use the psychiatrist, like as you've said, Eden, for those reasons. Or if there are a lot of hallucinations and we're not doing the best job of getting those under control, so you feel the most like yourself, or if you're feeling too drugged or different things, then often we'll bring them on as well. Or if there are some like impulsivity issues, which can happen in Parkinson's, and some of the medications cause that, we will also use them. Or sleep sometimes, if we're really having trouble managing your sleep and we've taken every feather out of our cap to figure out how to do it, then sometimes we'll do that as well. Same thing with the anxiety. A lot of times I tend to use them for anxiety, because again, there are a few types of Parkinson's that really have some tough anxiety, that it's faster for the anxious person to have them managing that than us. But they're always a good resource. There's no reason you couldn't go see them at any point, really, if you're having any mood or issues. But they are, as far as different from social work, they see you more routinely and follow up. And yes, they can also prescribe medications, whereas a social worker cannot. Good question.
And then when you had started, I thought you kind of was making a joke, but somebody did ask, and I was like, oh, I guess that's a good point. You said you don't like the treadmill. And is that just a personal, you don't like it, or you don't like it for Parkinson's patients?
I actually don't like it for Parkinson's patients, but this is an ongoing debate between us, not us, but providers and physical therapists. So physical therapists quite like the treadmill, and they often use you on it. And there's no wrong reason for that. The reason that I am always hesitant is because Parkinson's tends to be one-sided more than the other. So when you're on a treadmill, you tend to have one side that tires out more quickly, which increases your risk for falling. Now, if you've got your clip on and you're holding on and you feel really confident, that's great. You don't have to not do it by any means. But a lot of times we will defer to using a stationary exercise bike as being something that's a little bit more stable and not as easy to, if you tire on one side, the other side will just catch up with it. Whereas on a treadmill, you will eventually find yourself sliding off. So it just depends, but we tend to see more injuries on treadmills, but again, perfectly fine when you're doing physical therapy, or if you feel really comfortable on it and you're not having any trouble. I mean, by all means do so, but they're just a little bit rough, especially if you go, if you're feeling off, there's usually one side of your body that is moving a little bit more, and the treadmill is less forgiving than per se a stationary bike.
And then you kind of talked about some of the benefits of physical therapy that you will prescribe it for. Mm-hmm. Someone asked about, is this something that would be helpful for retropulsion, or is there something else you recommend for that?
Yeah, retropulsion, which is the fancy term for kind of falling backward. That happens in Parkinson's disease, as you may know, because your brain stops telling your feet when you're falling backwards. So it doesn't tell you, hey, you should stick your foot out, or, hey, you should catch yourself. It's not giving you that response. Physical therapy is our best tool for that. The medication rarely, but not often, is helpful. And same thing with stimulation. So typically therapy is our best way of doing that. So they can help you get a better idea of where your body is in space while trying to fight your brain a little bit, and seeing if we can restore any neuroplasticity and get you to not go backwards so often. But yes, I am very sympathetic. It is a very frustrating part of Parkinson's, and sometimes a walker is helpful for things like that, but sometimes not, because it's not behind you. So it just kind of depends. But physical therapy can be helpful for that as well. It is probably our best tool to at least decrease how often that's happening.
And then there was one slide where you kind of had the care team, if you will. And one of the things was a GE. And someone asked, what is that? Because I was kind of like, that is, because I usually think of general practitioner or PCP. And so what is the GE?
I believe it also is the general practitioner. It comes from the original slide, which I think was published overseas. And I think they refer to them as slightly different, but I can't remember what it is. But I think it's also supposed to be the general practitioner. Thank you for it's a good catch.
Because I was like, I didn't think about it. And then also someone asked, would you add the neuro-ophthalmologist to the care team?
would, especially if you're having, that's an excellent point, especially if you're having double vision. I think they can be really helpful with prisms or getting you the right kind of wetting eye drops because you're not blinking as much, which is causing some of that. So I definitely think that they're a good person to have on the care team as well.
And now, speaking of the care team, because somebody asked about this, they're like, how do you get all these providers to talk to each other? Does the care partner have to coordinate, or what do we do this? How do we get everyone to talk?
Yeah, it depends on where you are, to be honest. Of course, if you're so we have a multidisciplinary care clinic. So you see a whole bunch of people in one day, and you'll often find that at, some of the larger centers in big cities. Otherwise, you often do, as either the caregiver or the patient themselves, have to advocate for yourself, most unfortunately, because everybody does not talk well. If you're in the same system, you can at least ask for them to send notes to, will you please send this note when you're done with it to so-and-so and such and such. Sometimes I've just flat out asked other providers. I'm like, okay, great. So can you call this person at this number and discuss that with them for me? And that will work as well. But if you don't ask us to talk and we're not all in the same facility, it's not likely that we will. Not on purpose, just because that's a lot of care coordination and a lot of time. But I would say your best bet is to try to get into a multidisciplinary clinic where you are seeing all of those people together. After we do ours, we have rounds. So we each go around and discuss the patient, and we discuss the patient as a whole and the best thing to do about that. But if not, you're going to have to ask them to send notes to everybody. And if you have a specific question that you want them to ask, you're going to have to ask the provider to do so. You're going to have to advocate for yourself, unfortunately, at this point.
And then you had talked about pain specialists. Person stated that around here, the only pain specialists are interventional, which I know a lot of people have this situation. The only thing they do is injections, typically like epidural. What kind of pain specialists were you referring to?
Yeah, usually the interventionalists are the people that we use. And again, research shows us that Parkinson shouldn't cause pain, but if we're not treating your pain, it can worsen your Parkinson's. So, these things go together. To be honest, in general, we prefer the interventionalists because Parkinson's patients don't tolerate pain medications very well. They tend to make, especially strong ones, they tend to make patients hallucinate or feel groggy or increase the risk for falls. Not that, some people just need pain medicine for this, that, or the other. There's definitely a time and a place. But in general, we prefer the interventionalists. And sometimes we will also use PM&R, but they're so physical medicine and rehab. They also do a lot of Botox injections and things like that. But again, they're interventionalists at heart.
And someone asked, how much should a primary care physician know about Parkinson's? Now, I always kind of think people will say usually PCP is mile wide, but an inch deep. And so I was kind of wondering what you were thinking.
Yeah, I was a PCP for about 5 years. So I knew so little that it's probably awful. I only learned much more when my dad came down with it, or was diagnosed rather. So they have to be masters of everything. And so they don't know a whole lot. For us, if they're having, if we see a particular practice, we're always happy. Sometimes we'll do a luncheon with them, and we'll do a little CME with their physicians, their APPs, their nurses, everybody, and give them a little bit of training. Mostly what I really want your PCP to be able to handle for me as a movement disorder specialist is that if your symptoms suddenly get worse, which should never happen in Parkinson's disease, it's a slowly progressive disease. So if things are quick, then it's usually there's a catalyst. So you have a urinary tract infection, you have COVID, you're dehydrated, there's something else going on. What I am really happy if they will do for me is, run some lab work and just rule out or treat those things that can make Parkinson's quickly change. So that's how I like to use them in our care team. So, and I just keep an eye on their prescriptions as well, making sure some of the bladder prescriptions are things. A lot of our patients also use them to manage their mood medications. They're usually quite good at it. So we'll do it, or their primary care provider will do it. Same thing with sleep. So they don't know as much as we do, and they shouldn't, because we don't know all the things that they know by far. But again, if they're having trouble or we feel like maybe they're struggling a little bit, then we'll try to give them some continuing education. They're usually pretty open to it, and they're grateful for it. And, we just come in over lunch. We can't bring them lunch because that goes against the rules, but we show up at lunchtime, and we'll give them a quick little education, and that can help link some of those things. And I also like them when they just send me a message, if they have a question, at least if they've more recently seen you, they can throw those things to me and I'm happy to take care of them.
And then someone said, which I think we're all aware of, insurance can limit the ability to get the ongoing PT and speech and OT. Is there a way around this, or have you had success?
No, there's no way. There's not a way around it. Typically, they will pay for it 4 times a year, but not continuously. So usually what we do is we make sure you have a really good PT that's very confident with PD. They treat you for however many weeks, and then they will say, come back and see me in 3 months and we'll reevaluate and then go that way. So our physical therapists take a lot of that on themselves, and then they'll ask us for an order. But we also ask our patients at every visit, and do it that way. But you are correct. I have not found a way to get it covered all the time, even though it seems silly. What the insurance company requires is that you improve. And then once you've improved, then you have to stop where you don't improve. And then, you kind of feel like you're starting over. But a lot of what we try to bridge those with are some programs I saw fly up in there. Around here, we have a lot of Delay the Disease, or Rock Steady Boxing, or Parkinson's Dancing, or, some of those other classes to help. And then, of course, just doing the exercises they taught you in between, but that's not anywhere near as fun usually as some of those other classes and things. So we try to balance out the PT with doing some of those other community things that you're able to do.
Someone did ask your reaction to Rock Steady Boxing. I assume it's something you're happy with.
I quite like it. We don't have, I trained at Wake Forest in movement disorders in North Carolina. So we had a ton of it down there. It was booming when I left. And then when I came up here, we don't have as much of it. So I think they've just started releasing some actual clinical trials, or at least some kind of evidence for how helpful it is. But anecdotally, it seems to be very helpful. And I think it's good for patients to do, especially if it's something they like to do. I think that makes it more enjoyable, but it does seem to be helpful because it's a little bit newer. The evidence is a little bit thinner, but I think there are some trials. I have not looked in the past 2 years, but I think that there are some that show that it's helpful.
And then we have a question about, you mentioned the problem with protein, and that it can be hard to schedule the food around when her husband's willing to get up. Someone else agreed, that there's also protein issues. Is keeping the protein medication separate the only solution? Is this one of those times where people have to kind of rearrange the schedule that you gave them because it just isn't going to work otherwise?
Yeah, I only if patients have trouble with protein do I tell them to pay attention to this, because not all patients who have Parkinson's have to worry about protein. Okay. So first off, typically it's only not for everybody, but for the majority of folks, it's only large amounts of protein that come in things like Boost or protein bars or something that's artificially full of protein. Those I just tell my patients, please don't, wash down your carbidopa levodopa with a Boost or something to that effect, some protein shake. But otherwise, if it is bothersome to you, if you are one of those patients when it's bothersome, yes, you kind of have to plan around it for now. I would say re-ask me that question in about 3 to 6 months. We are hopeful that there will be some delivery devices for levodopa that may circumvent the stomach. That may come out, but they have not been FDA approved, that they have not come out yet. So I don't want to put the cart before the horse, but we are hopeful that will be, and I see the question. So the protein issue is that protein and levodopa are absorbed in the same spot in the stomach, in the gut rather. And so some patients, the protein will be more absorbed than the levodopa. So essentially you don't get as much bang for your buck out of the medication. Again, to be very clear, not every patient gets this. In fact, it's more of a minority. So I tell my patients, please, 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 please do not drive yourself crazy and around food and protein and meals. This is already hard enough to take it the several times we're asking you to take it per day. Only do it if you're noticing a problem where you feel like when you take a dose, it didn't really kick in or it's not strong enough. And that can come from other reasons other than protein too, to be fair, because we need you to hold your weight and we need you to stay steady that way. So we don't want to cause extra trouble. I don't want everyone running around trying to rearrange their meds around protein or anything, okay? But the issue is absorption. Now, on the same hand, though, you may fully well absorb this levodopa, no problem. And the protein has to wait to be absorbed until later. So there's no telling how that works. So again, only if you're noticing more off time, let's say 30 minutes after you eat something with protein in it, would I start to be suspect. Otherwise, I would not change what you're doing.
The nurse practitioner I used to work with explained this to me once. And I said, I was like, she's like, it's the same place in the small intestine that that the protein gets absorbed, where the carbidopa levodopa gets absorbed. I just remember I was like, so is it like Lucy and Ethel in the candy factory?
Yep.
Where like everything was coming down and they're grabbing it. And she's like, it's not something I would have thought of, but yes, I can see the analogy. She's like, of course I came up with candy. But she was like, I could see that, if you think they can only process so many molecules, if you will. And so that was always kind of when we talk about the protein issue, I'm always just picturing Lucy and Ethel.
I think I'm going to have to use that and add it to my repertoire. I think it's the next way to explain it. Mm-hmm.
So, does anybody have any further questions before we go? One of the questions did come up as to where you work. So we did talk about the fact that you are a nurse practitioner in the movement disorders at the Ohio State University Wexner Medical Center.
Mm-hmm. Yes, and I used to work at Wake Forest in North Carolina, also a lovely program. I can speak from personal experience, but the rest I know are lovely, but I cannot speak from personal experience.
Well, thank you so much for sharing this. Kelly already put in that to save your chat, there are 3 little dots at the bottom of your chat. I'm assuming that your chat is open, and if you click on them, you can pop up and you can save your chat. Clarice, thank you so much for your time today. As always, we have a tradition here, people are already starting to wave, where we do our wave of gratitude. So thank you so much. And we're so grateful you could join us today.
Yes, thank you so much for having me. If anybody has any questions, anything follow-up comes on, just let me know, and I'll make those slides available as well for anybody who might want them. Okay.
Thank you.